Welcome to the very first online pediatric anesthesia resident lecture. I'd like to first start out by introducing myself. My name is David Liston, and for acknowledging Vince for helping me with coming up with the topic as well as reviewing the topic, and for being open to having this topic online, enabling residents to view it at their leisure rather than coming to 6:30 a.m. lectures, which I never liked myself. Okay, so let's start. As an outline of the topic that I'll be discussing, first and foremost, pathophysiology, followed by signs of MH, the genetics of MH, prevention and preparation, what to do to avoid MH altogether, and how to be prepared if you do see it. Some mortality issues, acute phase treatment, which is broken down into 7 steps. Then following this, we will be discussing the more acute presentations, or more common presentations, 2 examples of such, what to do in the post-acute phase, and then finally I'll be showing you a very helpful iPhone app. So you'll notice that there are 4 titles on here that are in red, and they all have arrows that point from the MH hotline. There is a MH society known as the Malignant Hyperthermia Association of the United States, or MHOS. That was established in 1981, and they produce an emergency therapy for malignant hyperthermia poster. This poster outlines the very basics as to what the anesthesiologist should know in regards to MH. And from this poster, directly from this poster, are the portions of this outline that are colored in red. So the signs of MH, acute phase treatment of MH, 2 of the more common presentations, and the post-acute phase. So this information is up to date as of 2014 from this poster and from this society. Okay. To first discuss pathophysiology, it's important to know that it's a skeletal muscle disease that has pharmacogenetic properties. And its primary trigger, as we all know, is inhalational anesthetics and succinylcholine. There are, in fact, other drugs that could potentially trigger MH, but the only ones that we interact with are the inhalational anesthetics and sucks. So what happens when a patient is exposed to one of these triggers is that an uncontrollable release of calcium occurs from the sarcoplasmic reticulum, and this release of calcium results in muscle contracture that is sustained to the point where, if this occurs for a prolonged period of time, creates a hypermetabolic response. Okay, our next slide discusses the signs of MH, which is what a lot of people are mostly concerned with. And it's important to know that the signs are variable in both degree and onset. So it's difficult to definitively say what any patient that experiences MH will or will not have as to these symptoms. The earliest sign is an increase in tidal CO2 that cannot be decreased with a change in mechanical ventilation. Other common signs are tachycardia and tachypnea. Experiencing jaws of steel or masseter spasm or trismus is one of the examples that we'll give as one of the more common presentations. This is also followed by truncal or total body rigidity. And it's important to notice that these muscles are contracting continuously and will not be affected by non-depolarizing neuromuscular blockers. So giving a non-depolarizing neuromuscular blocker will not cause muscle relaxation and or relief of the symptoms of MH. Since, as we know from the pathophysiology, this is all related to uncontrollable release of calcium. An actual rather telling sign is a mixed respiratory and metabolic acidosis. I noted first that the increasing entitled CO2, which you would think would lead to an initial respiratory acidosis, but as this is also a metabolic process, both are evident rather early on. Increased temperature, when you think of malignant hyperthermia, that's obviously the first one that you would consider, but it's actually a late sign. And you also want to be looking at the urine to see if there's a change in color, to see if myoglobinuria is occurring. And finally, hyperkalemic cardiac arrest. So this also leads to increases in potassium that can cause cardiac arrest. Okay, let's go back to the genetics of this disease. It is autosomal dominant, but as I mentioned before, it's expressed in a very variable pattern, in an unpredictable pattern. In fact, patients with MH can have many prior uneventful general anesthetics, but it's important to note that once a MH response is triggered, every subsequent anesthetic will always trigger the same response to those inciting agents. The actual receptor that MH has been localized to is the ryanodine receptor, also known as the RYR1 receptor, and this is on chromosome 19. So what is this receptor responsible for? It is a large channel in the sarcoplasmic reticulum, again, where calcium is released. And as we discussed in the pharmacogenetics of it, it's the interaction of actin and myosin that causes muscle contraction, and this is all stimulated by the release of calcium. There is not just one potential mutation within this receptor that can cause MH. There's actually more than 160 and counting mutations. Having said that, these patients do not exhibit overt myopathies. They actually function normally, and this is typically the first time that any type of issue with muscle contraction is ever experienced. The majority of these families lack familial history and or personal history of MH. This slide is taken from the 4th edition of Cote, page 857, and in case you didn't believe me, this lists all of the known malignant hyperthermia mutations within this one gene on the 19th chromosome. Okay, to discuss prevention and preparation. If no history of a blood relative with MH episode or myopathy with high concordance to MH, so this first bullet point is saying if there is a known history of the patient having a blood relative with an MH episode, or if there's a myopathy that's known to be in high relation to MH, then the most reasonable option is to consider a non-triggering anesthetic, and that's typically a total intravenous anesthetic, or TIVA, or a regional technique. Either one of these techniques would be entirely safe. Since we always have succinylcholine as a rescue drug that is readily available, it's important to make sure that succinylcholine is not readily available, since giving it in a case when you think perhaps it's needed to be given in an emergency and not recognizing that this is an MH-susceptible patient, it could inadvertently cause this type of response. So all vaporizers should be disengaged from the anesthesia machine. This means that rather than simply being certain not to turn the vaporizers on or putting tape over the vaporizers, it's actually it's recommended policy to physically remove the vaporizers from the machine, and then to flush the anesthesia machine with 10 liters of oxygen as to get all of the remnant inhalational agents out. And it's important that you do that not with just the flows at high volumes, but also to turn the ventilator on so that the bellows are working. Also replace the CO2 absorbent canister and use a fresh circuit. I know that at Children's, especially at Bellevue and also in our MRI area, we do use the same circuit with the filter between the mask and the circuit, so that we can use one circuit for the entire day. And it's important to not do that and to have a completely new circuit for these patients. And then, of course, as is an ASA standard monitor, please be measuring core temperature, which I think would be intuitive. Okay, on to mortality. So it's interesting to note that mortality in patients with MH has decreased from 80% in the 1960s, which is quite high, to less than 5% now. So this slide discusses the 5 reasons why this has occurred, which is rather dramatic. The first being that we simply better identify these patients, and making that a common question that we ask on all preoperative phone calls, on all preoperative assessments, that we screen these patients and eliminate that exposure. So MH families are also more aware and are more likely to discuss these issues with their physicians preoperatively. And then compared to the 60s, we do routinely use capnography and pulse oximetry, whereas then they did not. And therefore, these different signs that we talked about, with increasing end-tidal CO2 being the earliest sign, can be more easily picked up quickly. 3, the better understanding of the pathogenesis. So we know which drugs trigger this. We know that we should avoid those drugs. 4, widespread availability of the treatment for MH, which is dantrolene. And the beauty of dantrolene is that it readily aborts the reaction. The next is that we have steadily reduced the amount of succinylcholine in pediatric anesthesia. And this has occurred ever since a black box warning against the routine use of succinylcholine in kids has been issued, and now we really only use it in kids that are where we definitively need to establish a rapid sequence induction to establish the airway. So especially reduced use of succinylcholine in kids less than 8 years old, specifically males with possible undiagnosed myopathies. Okay, so we're getting into the first of the slides that was taken directly from the poster put out by MHAUS. So the first thing to do when you suspect a patient with MH is get help, get dantrolene, and notify the surgeon. So stopping the volatile agent and or sucks if you're in the middle of pushing it is important. If you notice that the end-tidal CO2 is increasing, hyperventilate with 100% O2 at high flow, more than 10 liters per minute. In notifying the surgeon, tell them that they need to stop the surgery as soon as possible, and only continue once MH is treated appropriately if the surgery is in fact emergent. It's important to note also, do not waste any time in changing the anesthetic circuit or the CO2 absorbent. It will simply distracts from the main issue, which is to abort the chemical reaction, and by giving dantrolene, and to take supportive measures. 2, in giving dantrolene, what do you need to know about that? The dose, 2.5 milligrams per kilo IV. Hopefully you have hopefully you have a large IV that you can rapidly infuse, since it is typically a larger volume, which I'll show in a minute. How do you prepare dantrolene? And in case you haven't seen dantrolene, it comes in 20 milligram vials of yellow powder, and these need to be dissolved in 60 mLs of sterile, preservative-free water. So MH kits come with 60 ml sterile, preservative-free water vials, multiple of them, and as well as 20 milligram dantrolene vials. So the two need to be combined into a 60 cc syringe. And this needs to be given quickly all the way until you've given 2.5 milligrams per kilo. Sometimes more than 10 milligrams per kilo is necessary, and it's been reported as high as 30 milligrams per kilo, which is quite a large fluid volume in most patients. You want to repeat the dosing of dantrolene until signs of MH are reversed. And then just as a side note, each 20 milligram bottle has 3 grams of mannitol, which is added to balance the pH solution to 9 and create isotonicity. This picture shows the red-capped bottles that have the dantrolene, the yellow powder, and the blue-capped, slightly larger bottles or vials that has the sterile, preservative-free water. And as you can see, there's 12 bottles of each. This next slide shows the process of adding the sterile water to the dantrolene so that it can be mixed and then pulled out in order to give. Okay, the mechanism of action of dantrolene is that it directly binds. It's a direct acting, skeletal muscle relaxant. And it does this by binding to the ranitidine receptor where the problem is, where there is simply a release, an over-release of calcium, and it blocks this release of calcium from the sarcoplasmic reticulum. So you have this receptor that's openly releasing calcium. You're blocking that receptor, and keeping that calcium release from occurring prevents the intracellular increase in calcium that's needed for the sustained muscle contraction. And since that's not occurring, the sustained muscle contraction stops. It interferes with the coupling of the muscle fiber excitation contraction, and essentially breaks that process from continuing to occur. This last slide, at least the third thing that they mentioned, is bicarbonate for metabolic acidosis. That's one of the other things. This is, of course, after you've been giving dantrolene and or reversed the process, but you want to consider treating the metabolic acidosis with 1 to 2 milliequivalents per kilo of bicarb. At least if your blood gas values are still pending, and once you have blood gas values, and as you get those, you can treat according to how severe your metabolic acidosis is. 4, cool the patient. If your core body temperature is greater than 39 degrees Celsius, you want to do this. You want to lavage open body cavities if there happens to be open body cavities. Apply ice to the skin. Use cold saline intravenously. And then in anyone who's done anesthesia for a period of time, you know that when you start cooling, you want to prevent that drift. So you want to stop cooling if the temperature drops below 38 and continues to fall, because once you start to cool and you cool rapidly, you can drop the patient's temperature significantly. Dysrhythmias are a common complication of MH as well. They usually respond. So if you're treating the acidosis and you correct the acidosis, typically the dysrhythmia will resolve. That's the important note here. Using standard drug therapy. So if other dysrhythmias are still occurring despite that, you can use any one of several medications to treat them, whichever dysrhythmia you are experiencing. But do not use calcium channel blockers for obvious reasons. Calcium channel blockers can actually result in the exact opposite effect. As opposed to treating the dysrhythmia, it may cause a complete cardiac arrest in the presence of treatment with dantrolene. So you can get AV block or VFib or even decrease myocardial contractility. So, yes, treat the acidosis, use whatever drug therapy is appropriate for the dysrhythmia that's being experienced, but do not use calcium channel blockers. Okay, we discussed a little bit about hyperkalemia, but to get into the specifics, if you are checking blood gases and hyperkalemia is present, it's important to treat with things you would normally do to treat hyperkalemia. So hyperventilation, bicarbonate, insulin, and subsequently, since you're giving insulin, also glucose, as well as calcium. So bicarb, we talked a little bit about 1 to 2 milliequivalents per kilo. Can also be used to treat hyperkalemia, in addition to the treatment of the metabolic acidosis. For insulin, the recommendation by the society was to give 0.1 units of insulin per kilo and 2 milliliters per kilo of D25, 25% dextrose. In adults, 10 units of regular insulin IV and 50 mils of D50 can be given. Calcium chloride or calcium gluconate, if life-threatening hyperkalemia exists, calcium chloride in doses of 10 milligrams per kilo and calcium gluconate in doses of 10 to 50 milligrams per kilo. And then be sure to be checking your glucose levels hourly, which I'm sure if you're checking ABGs, you'll be checking that as well. Okay, 7. Labs to be following. End-tidal CO2, lights, VBGs, those all seem to be rather intuitive, but other labs to follow are creatinine kinase, which is CK, serum myoglobin, coags, and then also just looking at urine output and color. So if the CK or the potassium rise or the urine output falls to less than half a mil per kilo, then you need to be concerned about myoglobinuria-induced renal failure occurring as a consequence of MH. And to prevent this, you want to start treatment of diuresis to increase urine output to more than 1 mil per kilo per hour, as well as giving bicarb to alkalinize the urine. It's important, in order to know that you are in fact diuresing adequately, to place a Foley and monitor urine output more closely. And then when you're getting to this point where you're actually managing a patient that is very sick, consider placing a central venous line as needed. Also, we talked about calcium chloride. That's something that is usually better given through a central line anyhow. Okay, 2 more common presentations of MH. I have some pictures here of the Masseter muscle as well as peak T waves, just to give a prelude to what we'll be discussing. This again is taken from our MH Society. Sudden, unexpected cardiac arrest in a young patient should be a clue that malignant hyperthermia is possible as a cause. So automatically presume hyperkalemia and initiate treatment. Measure CK, myoglobin, and ABGs until these all normalize. Consider dantrolene, and it's all usually secondary to an occult myopathy, typically an undiagnosed muscular dystrophy. And it's important to note that resuscitation may be difficult and or prolonged. Okay, so that's the first more common presentation of MH. The second is trismus or muscle masseter spasm that occur after succinylcholine. Trismus or masseter spasm is an early sign of MH in many patients, and if limb muscle rigidity occurs, obviously consider giving or beginning treatment with dantrolene. If it's an emergent procedure, continue with non-triggering anesthetics or agents, and evaluate and monitor the patient very closely, and consider giving dantrolene. Switching to non-triggering anesthetics, even if there are no other signs of MH. So even if only masseter spasm or trismus is the only sign, still consider switching to a non-triggering anesthetic to avoid further propagation of this type of pathophysiology. And again, follow CK and monitor for urine myoglobin for a subsequent 36 hours. If you're checking CK, immediately then do it at 6-hour intervals. Again, watching for signs of myoglobinuria, such as darker Coca-Cola-colored urine. We talked about liberalizing fluid intake or giving IV fluids in higher volumes. And watch the patient for at least 24 hours if this is a true concern. In other words, admit the patient. Okay, post-acute phase. What to do when the patient has experienced an MH episode and been treated, and now you're debriefing and deciding what the next step is. So counsel the patient and the family regarding MH and both what occurred and what types of precautions should occur in the future, what things they need to know about in order to prevent this from occurring again, and what they should be telling their anesthesiologist in the future. Refer to the MHAUS Society for further steps and advice as to how to proceed. And one of the ways that we do that is there is a form on their website at www.mhreg.org. It's titled the Adverse Metabolic Reaction to Anesthesia Form. This will get them entered in the database and also hopefully have them at least put in this database so that more recognition of future occurrences are identified. And then send a letter to the patient and their physician so that the patient can take this to their physician as well as their primary care physician having it, so they can provide it for future anesthesiologists. Refer the patient to the nearest biopsy center. So they should be tested to definitively determine if they have this ryanodine gene defect. There are only 5 centers in the U.S. The closest to us is at UC Davis. The test that they do is the caffeine halothane contracture test, which is a great board-style question. That is the gold standard. Okay, so I'd like to finish with what I think is an excellent app. If you search on your iPhone under the Apple apps for MHAPP or MH app, this will come up, and this app will guide you for only $1.99. Will guide you through an MH crisis. It has weight-adjusted dose recommendations for treatment of acidosis and hyperkalemia and dantrolene, of which we all covered, but are easy to forget in any emergency. And then all of your actions are recorded in a log file and easily sent to the MH Center afterwards. This slide actually shows what the different screenshots look like. The general MH homepage, about MH, what it is, explaining a little bit more about each aspect of it. MH treatment, walking you through each step by step. It's a very clean format. It's very intuitive. The fourth screen there shows you that it's logging everything that you enter as to the time that you did it, as well as how much you've given, and produces an action log at the end. So again, I highly recommend that for only $2 that you have this available, as most people have their iPhone in the operating room, in case you ever experience a patient with MH. Okay, to go through the outline one more time, we did talk about pathophysiology and how that's important to know and understand this disease. The signs, what are the first signs of MH, what are the subsequent signs of MH, which ones are specific, which ones are non-specific. We talked about the genetics and the ryanodine receptor gene, chromosome 19. I think one of the most important things is talking about prevention and preparation, which we did. We also talked about mortality and why the mortality has decreased from 80% to less than 5%, and the 5 reasons why that has occurred. We discussed the 7 steps of treatment, as outlined by MHAUS. At least 2 of the more common presentations with hyperkalemia and masseter spasm or Trismus. what to do in the after the acute phase, as far as notifying the patient and referring them for further workup, and then we concluded with a review of MHAUS's iPhone app, which again I do recommend. So that concludes our presentation. I'd like to really thank you for taking the time out of your day to do this online, and please provide feedback if you feel that this type of lecture, having this type of lecture online rather than as a live 6:30 a.m. lecture, is beneficial. We really would appreciate any type of feedback that we get to improve the process. Thank you very much.